Thank you very much, and it's a pleasure to be here. So I have no financial interest in this talk, and I will discuss off-label use of medications. So as we go through our daily routine, seeing patient after patient after patient, and normal after normal after normal, it's easy to see how one could miss that patient with giant cell arteritis. So in this talk, our goal is to expand and highlight that one patient with giant cell arteritis that's hiding among our normal patients. So as we all know, giant cell arteritis is a large vessel and medium vessel vasculitis that typically affects older individuals. Vision loss occurs in about 15 to 20%, with ischemic optic neuropathy being the most common, but don't forget that retinal artery occlusions can also occur in giant cell. Women are more commonly affected than men, and Caucasians are much more affected than pigmented races. Generally speaking, these patients need to be over the age of 50, and usually these patients are in their 70s. So when we approach a patient that we're thinking might have giant cell, we have this laundry list that we like to go through, right? Do you have headache, scalp tenderness, et cetera, but they're very non-specific. And the more worrisome symptoms really are preceding transient vision loss, preceding double vision, and jaw claudication, so jaw pain with prolonged chewing. And you may have heard of DADT, which stands for don't ask, don't tell, right? So that applies to neuro-ophthalmology as well. If you don't ask the patient about their jaw claudication, they won't tell you about it. And that also leads to another concept, which is DWDA, which means didn't write, didn't ask. So when the lawyer is asking, doctor, did you ask this patient about jaw claudication? This is where we want to put our pertinent negatives in. I asked about it, patient denied symptoms of giant cell arteritis, denied symptoms of jaw claudication. So one of the things that we don't commonly check in ophthalmology is the temporal artery pulse, and that can give you a lot of value. So maybe it's normal, but if it's enlarged or tender or pulseless, it can be helpful in pushing you in a certain direction. So now I thought what we'd do is move to talk about some cases, and we'll use that to drive some principles. Now these cases are not completely bread and butter, but they generate concepts and principles that we'll use to help us determine how we could not miss giant cell arteritis. So the first case is a 93-year-old man awoke with painless, non-progressive vision loss in his right eye 4 days ago, states that his left eye is totally fine, denies any and all symptoms of giant cell arteritis, actually says that he's doing just fine. Has a history of atrial fibrillation and hypertension. He also has glaucoma, for which he takes the medicines listed here. And his acuity is count fingers at 6 feet in the right eye, 20/30 in the left eye. He's got a whopping APD in the right eye. His temporal arteries were completely unremarkable. So here are his optic nerves, and you can see that the right eye shows optic disc edema with scattered hemorrhages on the disc. The left eye shows a small cup to disc ratio. Perhaps there's some pallor present. So it's not clear why he received a diagnosis of glaucoma based on this particular optic nerve. And this is his visual field, and you can see that there's an inferior arcuate/altitudinal defect here, and this is the left eye. But the referring doctor says that this is completely the same for what he's had for years, and perhaps this is why he was told that he had glaucoma. So we obtained a sedimentation rate which was 35, CRP was 0.8, normal being less than 2, and he had this field defect. So he was diagnosed with non-arteritic anterior ischemic optic neuropathy in the right eye, perhaps old AION in the left eye, follow up in a couple of weeks unless you're getting worse. And then he came back saying he was getting worse in that left eye. So he's hand motioning count fingers at this point. He still has an obvious afferent pupillary defect, and now his temporal arteries are enlarged and they're without a pulse. So we obtained a fluorescein angiogram, and when you do a fluorescein angiogram, typically the choroid will fill within 3 to 5 seconds. So from the moment the choroid begins filling to the moment that it's completely filled, it should be between 3 and 5 seconds. And you can see that he has a whopping choroidal filling delay, which is nearly pathognomonic for giant cell arteritis. And this is the left eye, the second eye that was involved. So I got another SED rate, and the SED rate actually went down, so he's now 25. His C-reactive protein is still 0.8. He underwent a temporal artery biopsy, and this was abnormal and consistent with giant cell. He had been admitted for IV steroids right away, and thank heaven, right, that his visual acuity improved to 20/50. And we did another fluorescein angiogram. So this is really kind of interesting, right? Another fluorescein angiogram the very next day, and you can see the choroid is filling normally. So this gentleman had giant cell arteritis. He was 93. He had no symptoms. He had a normal SED rate, normal C-reactive protein. So I'd like for you to think in your mind what you would imagine to be a normal SED rate. Is it less than 20, less than 30, less than 40, or all the above are possible? And when we think about SED rate, there are a couple of ways that people throw out there. One of them is suggested by a guy named Neil Miller at Hopkins, and he suggests using age divided by 2 for men, and age divided by 2 plus 5 for women. Women have a higher SED rate, and I assume it's because women are a little bit more inflamed than men. But it's just a known issue that women have a higher SED rate than men. Hay at Iowa suggests using 17.3 plus 0.18 times the age. And he, again, uses a higher value for women. I like to use the one by Miller. I think it's a lot easier to remember, and you don't need a calculator to try to figure it out. I think this case also raises the question, what's a normal CRP? And so again, I have listed 0.5, 0.8, 1.0, 5.0, and all of the above are possible. And most laboratories use 0.5 as their cutoff, but that comes with a caveat, and that is for milligrams per deciliter. And I don't know why some labs do this, but they choose to report, some labs choose to report their values in milligrams per liter, and that'll make it an order of 10 off. So when we think about hemoglobin, right, if I say hemoglobin's 13.2, you know exactly what I'm talking about. If I tell you that the CRP is 4, that could be something that's super high, or that could be something that's really normal. And so CRP is one of those few labs that you gotta carry the units with you, and you gotta know what the normal lab is for that particular institution. And then when you look at institutions, their labs will report that it ranges anywhere between 0.5 to 2.0. So personally, I like to use the CRP lab value, what's normal for that lab, as my cutoff. So what's the sensitivity of this? It depends on what numbers you use. So in this paper right here, they looked at SED rate 22 and 29 as their cutoff, so just a number, and they found a sensitivity of 84%. They used a CRP of 0.8 and a total combined sensitivity of 91%. Whereas in this paper by Parikh, they used the adjusted value per age that Neil Miller suggested, got a lower sensitivity, but a CRP greater than 0.5 and found a combined sensitivity of 99%. In either case, whatever you use, there's a very high sensitivity using both the ESR as well as CRP, but that doesn't give you the specificity. It just gives you a sensitivity. So it's been quoted very often that 1/5 of patients with giant cell could have either no symptoms or they could have a normal SED rate. Why would they have a normal SED rate? Well, this paper here by Head might give us some clue. They looked at biopsy-proven cases, and they compared the SED rates on statins versus non-statins and NSAIDs versus non-NSAIDs, and they found a statistically significant difference in the statin users and also the NSAID users. So perhaps these patients have normal SED rates because they're on statins and NSAIDs. CRP did not find that same statistical reduction, so CRP looks like it's a much more robust laboratory test when we're investigating for giant cell, and we should order a CRP in every individual. So what are the key issues here? We always want to rule out giant cell arteritis in a patient, older patient with vision loss. SED rate and C-reactive protein combined are highly sensitive. We want to know what the CRP normal lab values are. Systemic symptoms are not required for the diagnosis. And then fluorescein angiography can be extremely helpful in creating a diagnosis in a patient. So the next case is a 72-year-old man, developed binocular double vision 2 days ago. It's now gone. He had an MRI yesterday in the emergency room, and this was normal. And he denies symptoms of giant cell arteritis, 20/20 acuity in both eyes, eye movements are full, and he's orthophoric. So Tim probably recognizes this patient. He saw this patient, and this is his fundus exam. You can see that he's got a cotton wool spot here. So that's kind of ominous. It's really way off the disc. He doesn't have diabetes, doesn't have a good reason for that. But let's just keep that in the back of our mind. So Tim actually recommended that he have a SED rate and C-reactive protein, and you can see that his C-reactive protein was high for our lab. The attending that was over Tim had said, well, let's just ignore that and let the guy go. Guy comes back 4 days later, and double vision is back, and this time he's got some problems with his vision. So although his acuity is 20/20 and his color vision is normal, now he has an afferent pupillary defect in the right eye, and now he has pain in his right eye. He does have a misalignment consistent with the double vision that he's been describing, and his fundus exam, meaning the optic nerves, still look normal, but except for that cotton wool spot that's located off the disc in that right eye. So here are his visual fields, and you can see that the left eye looks really quite normal. The right eye has a superior shallow defect in that right eye. Now you may say, well, that's just ptosis. Well, he didn't have ptosis. He's got an afferent pupillary defect, and he's got a cotton wool spot off the disc, all very concerning for giant cell. So because his fundus looks pretty good, he had an MRI which shows no abnormality of the optic nerves. If it had shown something like this, it may suggest an inflammatory or an infectious cause. So now he has a diagnosis of posterior ischemic optic neuropathy. And topping the list of PION would be giant cell arteritis. Sometimes we think about major blood loss, sometimes we think about occurring right after major spine surgery or heart surgery, and it also could be idiopathic. But in this particular individual, giant cell arteritis is something that's very concerning. So he was given IV steroids. He had a biopsy that was not positive. However, we elected to continue treating him for biopsy-negative giant cell arteritis. And just to show you that this was truly PION, this is him several weeks after he had initially presented, and you can see that there's thinning of the nerve fiber layer here. He continues to have this persistent visual field defect, and he has never had the double vision again. So again, not your typical case, and fortunately, he never really lost a tremendous amount of vision, but double vision antedating vision loss is extremely concerning. The man has posterior ischemic optic neuropathy, and he has a cotton wool spot off of the disc, and all those things are very concerning. I think one of the key issues is if you're going to order a sed-latent C-reactive protein, then you better be prepared to act upon them. It's on the chart, and so if the patient comes back with giant cell, you ordered it, it was high, and you didn't do anything about it. And then just keep in mind, I know we're used to seeing that patient, like the first patient, coming in, count fingers or hand motion, but patients can begin with very mild vision loss, and it could be an opportunity to save their vision. Next case is a 77-year-old woman. She's got new headaches. So new headaches in an older person is very concerning. She states it hurts to chew. Her sed rate is 77, and her C-reactive protein is 57. This is a slam dunk, right? Absolutely no question, this has got to be giant cell arteritis. So again, I think the thing that you need to think about in your mind, how big of a temporal artery biopsy specimen should we get? No minimum 1 centimeter, 1.5 centimeters, at least 2. So the patient went to a general surgeon, and this is what happens quite frequently. And general surgeons tend to biopsy right in front of the ear because that's where you can almost always find it. And if you go further away, you can see that the arterial anatomy changes. So the general surgeon got a 3 millimeter biopsy on one side, 6 millimeter biopsy on the other. Here's the op note from that biopsy. They took out the right one and put it on a foil, and then they come back and it was gone. So then they looked around and they found it on one of the sponges, and they sent it off to the path lab. So we get this report, 3 millimeters left side, 6 millimeters right side, and the left side was actually an artery, and the right side was really a blood clot that they found on one of those foils, or sponges. So the path report came back, lymphocytic infiltrate, suspicious for giant cell, but too small to know if this is really giant cell arteritis. So unfortunately, and this is before she came into our care, the primary care docs took her off steroids because she had a negative biopsy. So she came to the university a couple of weeks later, and unfortunately she's NLP-OU at this time, and she's still NLP-OU. And you know, it's too bad, right, that this happened the way it happened. If you look in the literature, the minimum specimen size, it really should be at least 2 centimeters. And if you take 2 centimeters off of one side, the sensitivity of that is about 87%. Looking at all the ophthalmic literature, if you biopsy the second side, you can get another hit of about 5%. And so my policy is I biopsy one side. If it's positive, we're done. If it's negative, you have to think, is this really a high chance that this patient has giant cell? If so, then we biopsy the other side. If we think it's not likely to be giant cell, I think you can just stay with just a one-sided biopsy. So not all biopsies go well, and sometimes you get a vein or a nerve instead of the artery. And what that can do is cause there to be a facial palsy, and sometimes that facial palsy can be permanent. It's easy to see how that could happen. The temporal artery, one branch, the frontal branch, lies very close to where the facial nerve is, and so that leads some authors to put the incision further back in the hairline, and it's nice. It hides the scar. It's very uniformly there, and you're unlikely to damage the facial nerve. Are there any other non-invasive ways for us to diagnose giant cells? So this is kind of a hot topic. So folks are trying to use ultrasound to ultrasound the temporal artery and determine if there's giant cell there. So what they're looking for is something called the halo sign. So you have a hypoechogenic artery wall that's full of inflammation, and it's called the halo sign. So there was a meta-analysis done of 17 studies, and they found a sensitivity of 75% and a specificity of 83%. But if you look at the details of this study, one of these had only a 17% sensitivity rate. So to me, that says that there's a tremendous amount of variability in who's reading it and perhaps the technician that is obtaining the ultrasound. I don't think that this is a high enough specificity because it doesn't approach 100% the way that temporal artery biopsies do. The other thing that's kind of hot is doing MRI. So what you're looking for in MRI is thickening and enhancement of the wall of the artery, and this can be the temporal artery as well as the occipital artery. And you can see the difference on the non-involved side. 83% sensitivity, 71% specificity. Again, I still think at this moment in time, temporal artery biopsy is probably the way to go, right? You don't have as good of a specificity, and the cost for an MRI is probably similar to what that it is of a biopsy. So what are our key issues? We want to get at least 2 centimeters, and so somehow that has to be communicated to the general surgeon if that's who we're going to use, or if we're going to do it ourselves, we want to get at least 2 centimeters. I believe this patient who had the 3 millimeter and 6 millimeter biopsies could have had another one, and she probably should have if that was going to drive whether she had the steroids taken off. So you can biopsy the same artery on the same side if you need to. And then, despite a negative biopsy, she probably should have been treated and treated as biopsy-negative disease. So the next case is a 76-year-old woman who had a new onset left-sided headache. Again, very concerning. She's got a headache, eye pain, and neck pain. Denies other symptoms. She did not have symptoms of giant cell arteritis. Her acuities were 20/25 in both eyes. Her color vision was normal, and her pupils were unequal. The rest of her examination was unremarkable with the exception of her eyelids. So you can see that her palpebral fissure is smaller on this side. You can see that her pupil is smaller on that side, and she has a Horner syndrome. So painful Horner syndrome, knee-jerk reaction, right? She must have a carotid dissection. As we know, the oculosympathetics travel down over top of the lung, they go back up the common carotid, they bifurcate, and the ocular fibers travel with the internal carotid artery. So classic, does she have an internal carotid artery dissection causing this or not? So we usually scan somewhere between the skull base and the upper chest to see if there's an anatomic abnormality causing the Horner syndrome. So here is what we were hoping to see, this hyper-intense crescent within the carotid artery on the involved side. And instead, the neuroradiology fellow calls us, and this is towards the end of the day, so the attending had gone home. She says there's a tumor in the upper chest. It says a Pancoast tumor. So kind of interesting and kind of exciting, right? Never seen a Pancoast tumor at this time. And set up the patient to see oncology, set up the patient to see cardiothoracic surgery, and then that was a Friday afternoon. I'm sorry, not a Friday afternoon, it was an afternoon. And then the next day, the neuroradiology attending calls and says, that's not a tumor. He said that that's the head of the humerus. And you'd say, well, what's the head of the humerus? That's the number one question, right? Why is the humerus in the chest? And this is an artifact that occurs with MRI. So it has to do with how big of a field of focus do you use. So if you use a field of focus on the MRI that's smaller than the tissue that you're looking at, the MRI, for whatever reason, takes stuff that's off to the side and puts it on the other side of the scan. And when you look at it, it looks like the humerus. So obviously had to call the patient about this, and she was not amused. So eventually we got around to ordering a sedrate and C-reactive protein, and she had a biopsy which was positive, and she had a Horner syndrome secondary to giant cell arteritis. Now obviously, painful Horner syndrome, we're constantly thinking about carotid artery dissections. Sometimes it can be caused by certain kinds of headache syndromes called trigeminal autonomic cephalgias, and then maybe way down the list could be giant cell arteritis. Just to prove that this is possible, it's been reported. So there have been 2 cases of Horner syndrome from giant cell arteritis and 1 case of a Horner syndrome in a lady with carotid artery inflammation causing a Horner syndrome. So what are the key issues? Number 1, giant cell can rarely cause a Horner syndrome. I think the more important thing is, right, if you've got a neurologic deficit in an older individual, you have to at least consider the possibility of giant cell arteritis, and that neuroradiology fellowships are 1 to 2 years for a reason. So if you are faced with the idea that this patient might have giant cell arteritis, we really want to get a sedrate and C-reactive protein right away. If you are moderately suspicious, I think it's reasonable to start oral prednisone, high doses of oral prednisone. If you're highly suspicious or there's significant vision loss, then IV Solumedrol is also reasonable. I think it's also reasonable to start an aspirin on the patient and to obtain a temporal artery biopsy of at least 2 centimeters within the next 10 days. Why would you use aspirin? Well, we had written a paper a couple years ago looking at patients with giant cell, and of the 68 that were on aspirin, 16% went on to have some type of ischemic event, versus the 75 who were not on aspirin, almost half did. And there was a significant difference between those 2 groups. So I think it's reasonable to start corticosteroids and antiplatelet therapy for patients that you are concerned about have giant cell arteritis. So in summary, if you don't ask the patient about jaw claudication, they won't tell you. If you don't write about it, you didn't ask it. We worry when someone has transient double vision prior to vision loss in the older individual. We want to know what the CRP is for the lab that we're using. If we're going to get a biopsy, we should get one at least 2 centimeters in length. We want to start corticosteroids if we're suspicious that someone has giant cell arteritis, and I think we should consider aspirin use in all patients with giant cell as well. Thank you.